All right, everyone. This week, let's talk about substance-related and addictive disorders, as well as V codes. Substance-related disorders include 10 different, essentially, like kind of categories of substances. So there's alcohol, caffeine, cannabis, hallucinogens. I have plenty to say about that. I call bullshit on hallucinogens, but we'll get there. Inhalants, opioids, sedatives, hypnotics, and analytics, stimulants, including amphetamine and cocaine, tobacco, and then other or unknown substances. All right, so just some notes here about the different substances, the different classes of substances, things like that. So any substance that are taken in excess have a common direct activation of the brain reward system. So this involves both the reinforcement of behaviors and the production of memories. So in your chemical dependency class, you'll learn about this, of how substance use reinforces the behavior, and by virtue of just how it neurologically affects the brain, but as well as some, like classical conditioning and some operant conditioning in terms of reinforcements and rewards. So these substances produce an intense activation of the reward system, that to the point where normal activities may be neglected. So, the preference is to obtain whatever substance or to engage in whatever behavior is disproportionately in comparison to other activities or, substances, anything that you can kind of intake. They just don't produce the same levels of neurotransmitters of dopamine and serotonin, and the receptors. They don't activate the receptors in the same way. So instead of achieving reward system activation through adaptive behaviors, which we know are socially constructed, drugs of abuse directly activate the reward pathways. So these are also, risky in terms of involvement within the legal system. And the pharmacological mechanisms oh, sorry, I started coughing and couldn't stop. So the pharmacological mechanisms by which each class of drugs produces reward are different. So therefore, how intoxication looks and how withdrawal affects the individual all differ. And but in general, what all of the substances do is they activate this reward system. Again, they work on different receptors, and they produce feelings of pleasure, often referred to as a high. So Dr. Francis, as you read, does not love at all essentially the collapsing of substance dependence and substance abuse into just substance use. And I think he has really valid points that he makes regarding the kind of categorical difference. So, you're talking about kind of times in one's life or environments that kind of promote abuse, like college, where there's probably no future or propensity toward dependence. They were definitely could have met criteria for substance abuse. But what the collapsing in Dr. Francis's, in his opinion, what the collapsing does is potentially stigmatizes any use. That the implication is that if you use this substance at all in any way that might be abusive, that the assumption is that there's dependence, and that can have really serious ramifications for the person in terms of employment, legal status, if they ever, enter the court with custody issues. So any sort of legal proceedings, that could really hurt the person. So his thought is that substance abuse and substance dependence should still be different. They should be coded differently. They should be diagnosed differently. So just for the sake of us reading it, I'm going to give a nod to how these two differ. So in the DSM-4 text revised, the substance dependence and substance abuse were separate. Now in the DSM-5, they have been collapsed into just substance use disorder. I do not know what they're going to be doing with this, if they're going to be making any changes to this, category of diagnoses in the DSM-5 text revised, but I just wanted to give you all a little bit of a history. And quite frankly, if you conceptualize these two differently, you're free to do that. So with substance dependence, this is a tolerance, withdrawal, and compulsive use. Tolerance, withdrawal, and compulsive use are the three hallmarks of substance dependence. So a screening question: has anyone ever suggested that you have an alcohol or drug problem? And then these are all of the substances that were listed, except for, you can see like cocaine and amphetamine, they're collapsed into stimulant dependence. So this is just differentiating substance dependence from substance abuse. So substance abuse is serious adverse consequences occurring in the absence of tolerance, withdrawal, and compulsive use. So abuse does not have tolerance, withdrawal, and compulsive use as part of the criteria. And again, so you can see they're all different, but with substance abuse, a screening question for this is: have you ever gotten in trouble because of alcohol or drugs? So again, you can see that they're a little different, where substance abuse is, using a substance to the point of, pretty severe intoxication, but that not necessarily creating a tolerance, having, life-threatening effects of withdrawal, and that it's not, a coping mechanism. It's just, something that is done occasionally, but in excess. So with behavioral addictions, so in general, behavioral addictions are groups of repetitive behaviors. They come where a group of groups of repetitive behaviors can be things like sex addiction, exercise addiction, shopping addiction, but they're not included in the DSM-5 because there was not sufficient evidence to include them. So though they may absolutely be a struggle for your clients' patients, gambling addiction was the only behavioral addiction that was included in the DSM-5 because it had sufficient scientific peer-reviewed evidence to be included. So remember, the DSM is 100% in theory informed by research. So substance-related disorders are broken into essentially two groups. So we've got substance use disorders and then substance-induced disorders. So with the substance-induced disorders, these include intoxication, withdrawal, and other substance or medication-induced disorders. So these are things like psychotic disorders, bipolar, depressive, anxiety, OCD, sleep, sexual dysfunction, delirium, neurocognitive disorders. As we know, substance-induced disorders in terms of differential diagnosis are always a consideration. So and it can be like a specifier or classifier for these diagnoses as well. So each of the substances has substance use disorder except for caffeine. All the other 9 classes essentially of substances have both substance use disorder and substance induced disorders. Caffeine is the only one that has only substance induced disorder. So characteristics of substance related disorders is the cluster of cognitive, behavior, and physiological symptoms indicating that the individual continues using the substance despite problems with it, relational, occupational, legal. Like, it's basically like there's no consequence that is really able to, going to, however you want to say it, like stop this individual, which again is to me more indicative of dependence. But we're not talking about the DSM-4 text revised, we are talking about the DSM-5. So this is indicative of substance use disorder. An important characteristic is an underlying change in the brain circuits that may persist beyond detoxification. So particularly with individuals who have severe, so remember there's mild, moderate, and severe. We will talk about the different like kind of levels of substance use disorder, that there is neurological, physiological changes in their brain that we've learned from fMRIs and MRIs to be existing. However, the brain and the liver, the liver is incredibly resilient. For example, there is the stage of cirrhosis that it's difficult, if not at times impossible, for the liver to recover. But both the brain and the liver are very resilient because it's our detoxifying organ, that it's not just affected by alcohol, but that they're very resilient, and that these pathways and any sort of damage with treatment and with time can be improved. So symptoms of tolerance and withdrawal occurring during appropriate medical treatment with prescribed medications. Things like, if you are going to a methadone clinic or something like that, they are not counted when diagnosing a substance use disorder. So if it's under essentially medical advisory, so this is the same as like, as we know, prescription drugs can absolutely be a substance that people can have a substance use disorder with, because what they're doing is they are not using the medication according to a prescription or a doctor's orders. So severity and specifiers. What we know about substance use disorders is that they do occur on a range of severity from mild to severe. I will tell you how you, so essentially each of these substances have 11 criteria in criteria A for them to meet criteria for that one piece. So in order to be considered mild severity, you are meeting 2 to 3 of the criteria in criteria A. For moderate, you're meeting 4 to 5 of the symptoms. And then to be considered severe, you are meeting 6 or more of the symptoms in criteria A. Also, severe changing of severity is very common. So just know that that's kind of like a dynamic measure where, use can become more severe, it can become less severe. And then there are specifiers as well when you are diagnosing and coding substance use disorders in early remission, in sustained remission, on maintenance therapy, or in a controlled environment. And we'll talk about what each of those means in more detail. So like I said, substance-induced disorders, they include intoxication, withdrawal, and then other substance medication-induced mental disorders. So again, we've got substance use disorders and then substance-induced disorders. So I'm just doing the criteria 1 or criteria A for one of the substances, which is alcohol. So you can see here, so alcohol related disorders, that's the overarching kind of category. Alcohol use disorder, these are the 11 parts or criteria for criteria A. And then alcohol intoxication, alcohol withdrawal, other alcohol induced disorders are the alcohol induced disorder classifications. But I'm just going specifically through criteria A for one. Because again, since the substances act on the brain a little bit differently, the withdrawal symptoms are a little bit different, the intoxication symptoms are different. They're going to vary in this way. But again, remember, meeting 2 to 3 of these criteria is mild, 4 to 5 is moderate, and 6 or more is severe. So largely criteria A is a problematic pattern of use of that substance to clinically significant impairment or distress as manifested by at least 2 of the following that has occurred within the last 12 months. So you can look at that on your own. So like I said, all substances have slightly different intoxication and withdrawal criteria since all substances affect the body in a different way. And as I said, caffeine does not have a use disorder diagnosis. It's the only one. So then moving to a process addiction or a behavioral addiction, the only one that's included in the DSM-5 is gambling disorder. So here, there are 9 criteria for it. So in order to meet criteria, you have to meet at least 4 of these 9, and then you would be coded as mild if you met 4 to 5, moderate if the individual met 6 to 7 of the criteria, and severe if they met 8 or 9. So again, criteria A, you can see, is very similar here: persistent and recurring problematic gambling behavior leading to clinically significant impairment or distress, as indicated by the individual exhibiting 4 or more of the following in a 12-month period. And usually it's the last 12 months since you're seeing them now. So you can see here, there's different, needs to gamble with increasing amounts of money in order to achieve the desired excitement, is restless or irritable when they're attempting to cut down or stop, has made repeated unsuccessful efforts to control, cut back, or stop, is often preoccupied with gambling, having persistent thoughts of reliving past gambling experiences, handicapping or planning the next venture, thinking of ways to get money so they can gamble. They gamble when they're distressed. So it's, a coping mechanism for them. After losing, they return another day to recoup their losses. They lie to conceal the extent of how often and how involved they are in gambling. They've jeopardized or lost significant relationships, job, or other opportunities like education and career. They rely on others to provide money to relieve desperate financial situations that are caused by gambling, and the gambling cannot be better explained by a manic episode. So then we'll talk about V codes. So couple and family therapists in particular really thrive and live in V codes. So the issue is, these are essentially ways for you to better contextualize a client. And I encourage you strongly to use V codes and Z codes. They're just associated with the different ICDs. So these are conditions or problems that may be coded if it is a reason for the current visit or helps explain the need for a test, procedure, or treatment. So these are conditions and problems included in the medical record because they're useful information on the circumstances that may affect your client's care, regardless of their relevance for the current visit. So you have essentially choices of how to use these. Again, as I agree with Dr. Francis, I think these codes are underutilized. So use them liberally, use them freely, add context to any sort of diagnosis. So I won't go over these in exhaustive detail or anything, but essentially the bolded words here is the category, and then the non-italicized one are a subcategory, and the italicized ones are subcategories. So you can see here why CFTs may hang out in the V and Z codes. So in terms of relational problems, so again, maybe there is an individual who is presenting with anxiety, and given their current living situation or their current relational distress, that gives some insight into what may be contributing to the anxiety. So categories are broken up into relational problems, abuse and neglect. So again, abuse and neglect, highly associated with stress disorders, with dissociative disorders. So it's just giving some additional information about the client. Educational and occupational problems, housing and economic problems, other problems related to their social environment. So again, many of these just make sense to include, and you should incorporate them into your conceptualization and your treatment of your clients. So for example, if somebody is homeless, you're not going to necessarily go into these like higher order insight oriented treatment. Like you're probably going to try to, my hope is that you would figure out how to get a roof over their head, or at least like inadequate housing, that you would have some consistent and safe housing. Like if you don't have those types of things taken care of, none of the like kind of higher order stuff that we do in therapy will be effective. And quite frankly, these should absolutely be things taken into consideration when you're working with somebody. These are, to me, on the bottom of Maslow's hierarchy of needs, this is at the very bottom. These are having a safe environment, having food in your belly. These are experiences and needs that a person has a right to. And you can't really move up that hierarchy of needs without having the one previous to it or more foundational fulfilled. And it, like a lot of diagnoses, just makes sense. If somebody is homeless and they're constantly, for example, getting their belongings stolen from them, that may help understand some paranoid, what may, in isolation or in a vacuum be looked at as like paranoid delusions of, no place is safe, delusions of persecution, like that to me makes a whole lot of sense. So I encourage you to look over these V codes and really see what they're saying, and so how you can contextualize a client. Some other categories: problems related to crime or interaction with the legal system, other health service encounters for counseling and medical advice, problems related to other psychosocial, personal, and environmental circumstances. I think these are the last ones. Other categories. So again, please look these over, understand them. If you have any questions, please don't hesitate to reach out to myself or Ivy for clarification. So other circumstances of personal history, problems related to access to medical or other health care, and then non-adherence to medical treatment. So these are all essentially additional information that I would encourage you to use V codes, like I said, liberally, freely, in terms of how you are understanding your clients and coding their diagnoses.